Hello and welcome to Pediatrics, Nursing Care of the Children. I'm Mrs. Van Buskirk, and you will be hearing my voice in podcasts along with having me in lecture in the Lancaster campus. Just to let you know the way our program works, this course was developed by Mrs. Filborn from the Harrisburg campus, Dr. Bauer from our campus, and me from our campus also. We have collaborated to design a course that is comprehensive and meets the NCLEX plan for your success in this course. You'll hear my voice, you'll hear Dr. Bauer's voice, and some of the PowerPoints were created by Mrs. Filborn, some by Dr. Bauer. All have been tweaked and adapted for use on the Lancaster campus. So it is a collaborative effort. And this same course with the same information is taught on all three campuses, as well as the tests are reviewed by all three of us to make sure their integrity is excellent. Throughout the course, we're going to talk about advocating for children, providing their physical care, making clinical decisions, collaborating with families and interdisciplinary teams. We're going to talk about communication with the child and with the parent. We're going to talk about cultural diversity and how that affects the family and the child's care. We're going to talk about how to teach a child issues about their bodies, things they need to do, and also how we would deal with parents and family. And then lastly, we're going to speak on the issue of domestic violence and child abuse, and what we can do as nurses to, first of all, identify that and prevent it as best we can. In healthcare, we serve different populations, and as you've learned in your med-surg rotations, we can serve a lot of different family structures. We can serve a lot of very independent people who are being treated holistically. We can serve a population that's seen regularly by the doctor. And serving a family and providing family-centered care are two different things. When you provide family-centered care, you are looking at what affects the entire family. You can give a child, or let's say a teenager, instructions to take their medicine, to make sure their medicine is taken with meals, with food, whatever that instruction might be. But if you haven't investigated with the parents or the caregiver that, first of all, they're going to get the medicine for the child, and secondly, that they have the food or whatever else goes with it, then whatever teaching you've provided the child or the teenager is not going to be effective. Whenever you are providing family-centered care, you're involving both the child or the patient and their family or caregiver. The caregiver might not necessarily be a parent, it might be a grandparent, might be a foster parent, but you have to make sure that the parents and caregivers are always part of the care to provide family-centered good care. There's also a collaborative relationship that exists between a family and a healthcare provider. This is very important, especially when you're talking about getting a child started off in life appropriately. I currently work at WellSpan Ephrata Community Hospital, part of the WellSpan system, and when a baby is born into our facility, we give the family a list of providers that then become their family home, and we're going to talk, or medical home, and we're going to talk about that a little bit later. But in the meantime, when you're caring for a child, it is a collaborative relationship that involves the family, and perhaps if they're in a hospital or acute care setting, it'll be the doctors there, and then they will collaborate with that patient's medical home, which is where their basic care is provided. It is very important that we connect family-centered care with the medical home and provide care appropriately. When you're discussing the family-centered care atmosphere, you want to look at cultural diversity of the family. First of all, very simple things like what language do they speak? And are you providing education, information, and treatment in a language that they can understand? Another thing is to figure out coping mechanisms. People deal with stress differently in different parts of their lives, in different times of their lives, and we have to choose the teachable moment and when we can work with these families and it's best going to provide the best care for them. You also want to encourage family-centered peer support. So family to family, friendships in life come in here, and they make a lot of difference on how a child might thrive or cease to thrive. As I said earlier, we have to talk about the medical home, and we really need to encourage a family to have a medical home if they don't already. And what the medical home is, it's just a place, usually a pediatrician's office or practice, where all of that child's records are kept in one accessible place so that somebody is collaborating all of their care. It enhances access to community care. If you look at this little picture, we can identify and manage the patient population better. We can manage their care better, provide self-care and community support, track and coordinate care, measure and improve performance, and we can kind of see a template of what's to come in the future by having a medical home. To put it in the simple, basic form, easiest medical home to think about is a family practice that treats the child, keeps their immunization records, sees them for their medical well checks, that kind of thing. And sometimes you can have a medical home that treats the whole family, and sometimes it might be a pediatric specific sort of facility. When we talk about culture, there is no way around it. In the United States, we are a melting pot of diversity, and that is a blessing. And we have to make sure that we're meeting the diverse needs of all of our patients. In this area of Lancaster County, we have a huge Amish population, and their family structure is different. Their belief system is different. They use a lot of holistic treatments, and we have to be able to honor their wishes and then also provide the most adequate education and treatment that we can while still honoring their wishes. Again, we need to make sure we have language facilities available for people who do not speak English. We need to, if we have a patient who is deaf or if the parents are deaf, we need to provide sign language services. Those are just a few cultural issues. When we think of culture in the generic sense, we think, I'm American, I'm from the United States, and to be culturally different, you would have to be from Africa or India or South America. But that's not true. Within our own neighborhoods, we have huge cultural differences. Within our classroom, we have cultural differences. In your clinical packet, there is there's a map, and I highly encourage you to find the map and circle where you live on that map. In class, we're going to try and do that as a project together and see where we're all from. There's also cultural mapping questions. There's a sheet that gives you some questions to ask. We're going to break up into groups and discuss where do you live, where did you come from, what makes you who you are, and all of that helps us define our culture. And for those things, we have to be sensitive, and we need to really work with our patients to provide them the most culturally appealing situation that we can. Again, don't have to be from across the world to have a different culture. Also, as a nurse, you do not have to have a definite understanding of each culture, but you do have to be open to learning. So it is totally 100% appropriate to ask a family I don't know what you do, or I don't know what your dietary restrictions are. I don't know what your faith restrictions are, but I'd like to learn so that I can honor them. And that is almost always very, very, very well received by patients and their families. One thing I like to do with patients who speak another language, if there's a family member there, when I come in the morning, I'll say, if that family member speaks English, I'll say, could you tell me how to say good morning? Could you tell me how to say thank you? Could you tell me how to say I'll see you later? And then when I leave at night, how can I say good night to you? And by just saying a few words in someone else's language can bring them a lot of joy and certainly show that you honor their faith beliefs. I think the most important thing that we have to do as nurses is advocate for children. My pediatric experience is healthy children with acute illnesses. I was a camp nurse for 9 years. In the summer, I raised my own children at camp and provided nursing care for 200 children every week. I saw children who it was a healthy kid camp, so I didn't have like all autistic kids or all diabetic kids. It wasn't that kind of a camp. So I had a full spectrum. I had some type 1 diabetic kids. I had some autistic kids. I had HIV positive children. But for the most part, I had normal, healthy children who would come to me with belly aches and headaches and usually dehydration from playing too hard. I would watch their medications, make sure they didn't get lost, make sure they got their inhalers if they weren't breathing well, that kind of thing. And then I dealt with some pretty tough stuff. A child that I couldn't send back to their home because the child told me of several issues of abuse. I had a child who I sent home with one parent because they had broken their leg, and the parent didn't take him to the hospital and brought him back to the camp the next day with this ace bandage, horribly wrapped. Almost lost that child's leg because the father didn't want to pay the bill and was fighting with the mother. So there is a lot that goes on in pediatric care that is so far beyond the scope of regulating their blood pressure and making sure their cast is on properly. We sometimes are the only person that is there to protect that child. So we have to do the best we can to make sure they get the right kind of health care, that we're providing advocacy for the family as a whole and then for the child individually. If they don't have the financial wherewithal to have care done, we need to get a collaborative team together to find them the money to do whatever they need to do. And the money is usually out there. And through each step of the way, we have to take care of that child and love that child because somebody else in the world might not be. We also have to watch out for ethical and legal issues. Informed consent is mandated for children. Before informed consent can be given, before they can sign it, whoever is signing the informed consent must understand the risks and the benefits of whatever procedure you're going to do. That is the main tenet of informed consent. When a child has to have a procedure, and let's pick something very easy like an appendectomy. If the child is a teenager, it is more than appropriate, in fact it's necessary, that the procedure be explained to both the child and the caregiver. If the child's an infant, of course they're not going to understand what's going to happen. So the caregiver has to have a very, very good idea. And there's all kinds of ethical issues that arise when you talk about informed consent, children who want to be emancipated, children who don't, maybe they have cancer and maybe they're tired of treatments and don't want to do it anymore. And we're going to talk about this more in class. But one of the things I want you to know and remember is what's required for emancipation. Every state has different laws, but a child can be emancipated, first of all, if they're a parent themselves. So if a 14-year-old has a baby, that child, that 14-year-old is automatically emancipated. So they can make their own health care decisions that are different from what their parents might pick for them. Also, there's a lot of different reasons that a child can be emancipated. So you might